Guys, welcome to Clinical Unfiltered. I am Dr. Sausha, and today give me your hearts, minds, and teeth because we're getting unfiltered with Varisha Parikh. Dr. Parikh, you are a prosthodontist out of California, LA, that has not burnt down yet, correct?
No, I have not. We're still standing. We're still standing.
Speaking of burning down complications, we have decided she is a prosthodontist, and as a periodontist, who I actually do get called upon to be a perio hero in a lot of implant complications. We decided it would be fun for us to go down the shitstorm of implant complications that we, but mainly because right before you jumped on this podcast, as amazing as you look right now, you just dug in it with an implant. You fought with an implant. Can you please enlighten us on this story?
Yes. So this implant just decided to be naughty. So it's a cement retained implant crown on tooth number 6. It was a BioHorizons implant restored with a stock abutment and then a cement retained crown.
Stock abutment, cement retained. Oh, just rip it out. That is a naughty implant.
Yep. Yep. So you've got a crown that's like this big and abutments that's like this big.
I know BioHorizon has the like the impression. It's like an impression coping healing. Like it's like all in one. Comes with the implant. Is that the stock abutment that was used on the implant, or was it even a like a third party one?
I believe after getting into it that it was third party. I really do believe it was non-authentic because a lot of these implant companies will have color coded systems and BioHorizons is one of them. And so usually when I get into a situation, if I can at least see the color, then I'm like, okay, I know where this abutment is from, but this was just like straight titanium. So for me, I'm like, I have to believe that this is third party or non-OEM or like original manufactured parts. So yeah, it's a behemoth. And so essentially it's part of a larger restorative case. The general dentist referred it to me because they couldn't get into the access channel of the abutment. Now, the hard part of these situations is when someone attempts to retrieve something and then refers it to you after they've attempted. You are now not only combating the retrieval, you're combating the attempt that was made. And so again, I think a lot of this, and I know in your practice too, you sit down before you even touch a handpiece and you're just like, why was this done? Why is it cement retained? Why is it stock abutment? Why was the implant placed this way? And the most obvious why is because the angle of the implant is in a non-ideal position. It's probably coming out literally the straight buckle. And so the previous provider had to try to retrieve it from the lingual, which you weren't going to get anywhere with because everything's from the front. So
especially in the anterior. I feel like if it's cemented
especially in the anterior,
yeah,
exactly. So dropped in, think actually getting through the crown was a beast because it's a massive crown. But once we found the access channel, was grateful to the person who did it that they actually packed it with Teflon and something. They put Teflon over the screw.
Do you feel like, so when I'm in those scenarios, digging through someone else's crown and I pop through and I see Teflon, I get a little bit more hopeful that I'm like, okay, because versus like, I mean, do you judge people if they put cotton pellet versus Teflon? Because I do.
I absolutely do. I'm like, if my face didn't give it away, I absolutely judge.
Oh, they put a cotton pellet in here. They must be like over 60 years old.
Yeah. And this one I was actually more hopeful for because the Teflon, it's a colored Teflon. And when I lecture commonly, I think you've seen this in my lecture, I've always said that if you have any weird angles, especially if you do an angulated screw channel, use a different colored Teflon so you know that it's a different driver, right? So you're not going to strip the screw. So I got in there and I'm like, all right, I'm going to be a hero. Like I'm in the channel, I pull out the Teflon, the head of the screw blown away, like the whole thing the whole thing. And so it was very obvious that
Is that when you texted me saying I'm late? I'm going to be late for this podcast when you saw the head of the screw?
no. I literally told my assistant, she looked at me and she was like, ugh. I was like, yeah, I'm going to text him right now. But yeah, so essentially what had happened, or what became obvious to me, is that the abutment was seated and it was over torqued or incorrectly torqued with the wrong driver. It was then stripped and they probably couldn't retrieve it. So they attempted to turn it into crown and bridge and cement a crown on top of it. The way I was able to finally get it out is we cut like a slot, and I have a slotted driver, and I was able to engage the slotted driver and reverse it out. But it's a beast, and it's even harder when it's non-original parts, because all you're looking at, like when we're looking through our loops, is metal. Like it's just like a sea of metal.
I think when people when people are like, how do you get a stripped screw out? And it's like, look, I can explain it to you, but when you're in it, you're going to feel like you're just like, it's, like you're praying for good luck that it like catches something and spins out. Like you're not I'm sure even when you're doing your little slot, you're like, please, like, please do something. You're not sure. You're just like probably running it laterally, hoping it actually creates a slot. And then you stick your instrument and then catch.
And then even if you get the instrument, and this happened to me last week, Straumann implant, the previous provider seated a Nobel abutment on a Straumann implant, torqued it in. Yeah. So it cold welded the whole thing together. And I thought I was getting somewhere. I got the crown off. I could see into the access. I was able to get a driver to engage, and I went to reverse it. And yeah, the abutment came with me, but the head of the implant did too. So, I mean, I was like, you feel like a hero in a moment, and then you look at it and you're like,
you going into this complication with the patient, I feel like this is probably when I win most of the cases, because honestly, when I go into these scenarios, it is a little bit like, I don't know how this is going to play out. I think that initial touch communication with the patient is like going to seal the deal. You can relax a little bit as long as the patient's on board with the enigma you're about to go through. What's your like communication with the patient? What do you say to the patient before you enter this number 6?
no, you hit it on the dot. Like you have to over communicate like what is going on. So my policy for retrievals is we have obviously our consent forms and all of that stuff locked down, but essentially we have a flat fee. And that flat fee is for 3 30-minute slots, so an hour and a half. And essentially what it boils down to, it's around $550 for every half hour. And I tell them, I said, hey, this is going to be my approach. This is how confident I am in my approach. Every 30 minutes, I will stop and give you a status update. If I'm really not getting anywhere after an hour and a half, you have the option of coming back and having me try it again, or we can at that point decide to explant the implant and move in a more surgical correction realm. And I always tell them, I said, there might come a time where I open it up and after 30 minutes, I sit you up and I say, hey, the head of the implant has been floured, or I see a fracture at the head of the implant, or hey, I think there's some mobility in this implant. Then I'm going to tell you right away, like, I'm not going to sit here and pretend I can work miracles. I'm going to tell you like, hey, we need to bring our surgeon in and we need to do this surgically. But, I also think that like, especially for our general dentist listeners out there, like Sausha and I have the somewhat advantage of being specialists. Like by the time people come to us, they kind of have this preconceived notion that if we're not able to get it, it's going to like, that's kind of it.
Right. Like a dentist saw it as a problem and was like, go to this guy because and then they feel like this is the end of the road. So I got to do something with this guy.
Exactly. And that's why I think like, for some of my general dentist colleagues, like I will lecture on complications and want to empower them to see some of those more straightforward complications. But in part of that education, I always tell them, I'm like, you got to know your limit, because I can tell you that if you enter into this and you kind of muck up the attempted retrieval and then bring them to me, that I might not even have the option of trying to retrieve this. I might at that point be like, hey, they were trying to retrieve it and they tore off the head of the screw and I don't know what I can do.
Actually, yeah, that's a good point. Because like if they do send and it's why'd you even start and have this other, like, let's say I could actually continue to retrieve it, it makes the general dentist look like they've even got their pants further down. Like why, like I could have got this out in a cinch and you just, tried and tried and tried. I do get that notion. Your payment model is interesting to me. Where'd you come up with that?
Advantage of being a fee for service practice. So we don't bill insurance for any of this. We do have there is a retrieval code. So like for those people who have, insurance based practices, and we do help our patients bill to insurance if that's something that they want. So I had a faculty member in residency and he had essentially done this algorithm, this math, where he came up with his 30-minute fee for certain procedures. He's like, this is how much I think I need to make in 30 minutes for this procedure. And I just kind of extrapolated that to specifically screw retrievals because I think within 30 minutes, you can have a pretty good idea of where you're going. And that's not always the case. Like this number 6, I think the first 30 minutes, I thought I was a hero. The second 30 minutes, I thought I was going to cry. And then the last 30 minutes, I felt like a hero again. So he had a lot of emotions. Then that's why I give myself that hour and a half kind of ballpark. Also, there's a real person tied to what we do. Like the nerd in me wants to sit there for 6 hours retrieving an implant because I want to prove to myself that I can, but that's not fair to someone else. So,
I mean, out of curiosity, because like same here, after an hour and a half, like if I can't, there's probably undue damage to the point where we can't come back from it, from trying to retrieve the implant prosthetic complication. And at that point, you're right. The patient's been there. Like, really, how much more trauma are you going to do to them and ruin their whole perception of implant dentistry? And so after an hour and a half, you're right. If you can't get it out at that point, if you don't have the tools or the capabilities at that point, you can't. One of the tools, I don't know if you've ever, Salvin sells this screw retrieval tool. Have you ever used that or heard about that? I have. It's hit or miss, just like every other implant complication. It's not for the actual whole implant. The whole implant retrieval kit is good, but the actual like screw retrieval. And it's the same kind of concept. You like drill a hole on top of the screw and then it corks in because if it's stripped, it corks into the top of the prosthetic screw and screws it out. Or the cover screw or healing abutment, whatever prosthetic component. And with that, it's hit or miss too. But I do like having like as many tools as possible.
And I think like as practices that deal with it, we can also stockpile it. Like I have the Salvin kit, the Nobel kit, the Straumann kit, the Neodent kit. Like I have all of them. I even have like, this sounds again so nerdy and crazy. Like I even have drills of my own that I have kind of engineered. Like I've like, ground down certain like round burrs to get to the perfect diameter to like figure out what I need to get in a driver. And also like, I know in both of our practices, we've got universal kits for implants. We've got latch drivers. We've got, handpiece drivers. We've got long shank drivers. So that's like my big thing with implant dentistry in general is like, I want everyone out there to be doing this. Like implant dentistry is at a point where like we have a predictable outcome for our patients when done correctly. But also I want to educate people to understand that like our practice models are just inherently different. So if you come across a situation, it's not that you can't do it. I have confidence that if you had the right stuff, you probably could, but having the right stuff, the time, the technique, all of that is a different model in its entirety, right?
So with all those different kits, if you had to pick like, this is the one that gives me the most predictable retrieval of these prosthetic complications, which one is like your go-to? Which one's like, please put this first on the tray?
The Dentsply Sirona one is one of my favorites. It's called like the fragment fork and the fragment retriever. Those are great and they're very universal. Like you can use them for a variety of situations. And then my second one is the Straumann retrieval kit. The problem with the Straumann kit is that they don't manufacture it readily. It's not something that you could just like go buy. It has to be like per case, and you have to sign like a bunch of release forms and consent forms. But that once you have it, it's like fantastic.
And to clarify, these are for like prosthetic level complications. Like,
Yes.
okay, gotcha.
I'm stopping at the point where they need the implant explanted. Like at that point, when that comes up, I am referring to my perio colleagues and my oral surgery colleagues, and they are removing and grafting and then resetting for us.
I mean, you just the prosthetic complication you just described, number 6, anterior tooth, they had a prosthetic screw in, well, except for maybe the stripped top portion of it. I feel like I sweat the most when there is actually a broken prosthetic screw deeper inside the implant and it is not moving. Everyone's like, oh, it broke. Like the preload broke. You should be able to unscrew it out. And like, it's not always the case. And I feel like it's like 50% of the time it's the case. That's my most, like when I see it come in, I'm like, okay, we have a good conversation with the patient on how this is going to go potentially to the point, like worst case scenario, which has to be on the table, is implant removal. But then I start going through the steps to remove a fractured prosthetic screw deep inside an implant. And I feel like probably for most doctors, they'll see that more frequently than not. What's your approach? Broken prosthetic screw deep inside of an implant.
So the first question I ask is, was the crown loose before this happened? If there was mobility, then you're golden. You know you're set up for success because there was some movement in that screw. The preload was truly broken. So the approach there is, of course, make sure you have enough retraction. If the tissue is closed over, get the tissue out of the way. And if you have the data to say like, hey, it was loose before, then your only role now is to coax that broken fragment up. So a couple of things that have worked for me are using rope wax at the end of like an endo explorer or a really sharp perio probe. To, like putting it into the implant all the way to the broken screw and kind of like smushing it around so the wax kind of engages the broken fragment, and then slowly going counterclockwise. Every so often you have to take off the wax, put another piece of wax on because the stickiness gets loosened up, and then make sure you're going counterclockwise. Most common issue in this technique is people are going the wrong way. You're trying to unscrew it. Screw it down.
My assistant's looking at me like, what the heck is Dr. Sausha doing? I was like, I'm actually doing like righty tighty lefty loosey right now in my head.
Totally. The other thing that works for me in those situations is an endo file. If you can get a really thin NiTi file, NiTi files have memory to them. So if you can coax the file between the loose screw fragment and the wall of the implant, and again, go counterclockwise, periodically just pull straight up on the file, you'll notice it kind of just like pushes that screw fragment up a little bit.
I've never tried that. Interesting. I'm a perio. I don't have like a bunch of endo files, but I should. I'll try. I mean, trust me. Again, when you're in these, you want to have every tool you feel comfortably possible. So like, you tried everything before you explant the implant. So often I run into scenarios with this is when the doctor, like I send them back the implant to restore. And let's say it's like a smaller diameter implant with a smaller prosthetic screw. I'll get them tightening it or over torquing the prosthetic screw, and then it breaks. Those to me are kind of hard because they were never loose. They were tightened to the point where they broke. And then whatever's still in there is like, I don't know, almost like flattened out and has grip still inside the implant.
Those ones are the most challenging because you're right. They're like cold welded to the implant. Like they're so hard. My only hope for those ones is that I don't get them in my practice. But my second hope is what I have found that has worked. And again, I don't have like 15 or 20 data points for this. This has worked for a handful of cases, is essentially trying to core the inside of that broken fragment and piece by piece take out pieces of the screw. The hardest part about this is you're blind. You cannot see. There's no way you can see underneath it. You have to protect the internal hex of the implant because if your drill bangs it, then that's gone. And you have to make sure that it's really hard to center yourself, right? Because in a narrow implant situation or in an angled implant situation, you might think you're parallel, but the implant's like this. So if you're coming kind of straight, you might be actually going through the wall of an implant. And I remember a faculty member of mine, we had done a retrieval. It was in my residency, and he looks at me and he goes, "If it bleeds, you're in the wrong place because you punctured through the wall of the implant and you're in tissue now." So again, not like these aren't like fun. Like we don't like want to go through these.
How much do you think this matters? Because I've done this where it's like I have gotten it out in that fashion. By the way, those are like guaranteed an hour and a half. Like those take the whole time. I'm obviously like in those scenarios, there's definitely some threading damage on the interior of it. How much of that, like, do you think it could still work despite losing some of the threading?
I absolutely think it can still work, but I think it can still work because the alternative is so destructive, right? Like you have an osseo integrated implant that you're going to trephine out. Like I at that point, I think you kind of have to make it work. What's been kind of cool to see, and the longitudinal data is not there yet, but there have been a lot of case reports and case studies on doctors turning implants into doing like a custom cast, post, and core situation when they lose the internal hex that engages a crown. So imagine, again, they treat essentially the implant as a root canal, and they copy or they capture the internal connection that might no longer be engaging or is significantly disengaged, and they make a cast, post, and core and cement it into the implant and then turn this into crown and bridge. Now, I've only seen this in case reports. I haven't seen any like research on it, and I myself have never done it. But I think that what you're going to find, and what this tells me, is the trend now in our world of implant dentistry is how can we use them in situations where they might not be ideal. I mean, I see patients in my practice that have had chemo radiation and are not candidates for reconstructive surgery. I see patients who are super hypertensive, uncontrolled diabetes who are not candidates for surgery. So as a prosthodontist, it's going to be imperative for me to get uber creative and at least give that implant a shot.
Yeah, no, I mean, I have this one case I just posted on my Instagram. It was like a guy who had implants, like 4 or 5 implants on the lower, but throughout the course of having the implants, they had, radiation, throat cancer. They have a complete aspiration risk. You can't do predictable surgery on this guy. And he was sent as a second opinion because the first doctor wanted to do like rip out all the implants, do an all on 4, which, like if the other factors weren't at play. And I just did my 5-year post-op, and every single one of those implants is still in that guy's mouth holding his overdenture 5 years later. And this is a guy who has like he has to talk with why am I blanking on the word, but when you put the thing on the throat. so I mean, yeah, exactly. You got to try to make it work. I mean, I've seen also like if you damage the internal threads, they're like rethreading devices that you can place inside implants. I think it's only certain companies make it for certain implants, but they'll go inside the interior if you've damaged it to try to rethread it and have a design screw that goes into that rethreading of it internally. But yeah, that's like the worst. But I'll say the most common I think that I find is just it's simple as it's loose. And then it's and like that honestly most of the time makes me feel better. Right. I feel like a lot of times I can figure those out. Whether that be the crown's loose off the abutment. Most of the time it's like it's an internal hex implant, a tri it's one of those simple platforms like the conical or implants that have more they have like a deeper connection, and I feel like they are like not cold well per se, but are so tight fit that I don't see those get loose as frequently. But those internal hexes or those external hexes will get loose, and it's all about just like getting through the access hole. A lot of times I try not to damage the crowns. One of the tricks I use is I take a cone beam. If I know I have like a loose implant or an implant I need to get to the prosthetic access hole, I'll actually take a cone beam and do a topical scan as if I'm doing a surgical implant guide. I will then go into the software, wherever the implant is, superimpose my new implant over that and create a pilot hole guide. And if I use that pilot hole guide, and I track the exact direction, I often can get to the access hole with minimal collateral damage and be able to try to maintain that crown.
No, that's amazing.
That's my go-to move. That's because I do a lot of in-house guides, but
Talking about like the ones where you look like a hero. This was maybe like a couple weeks ago. A patient comes in, referred from oral surgery. They had taken a pano for something else, and they saw that he had implant number 30 that was buried under the tissue at this point, and that there looked like to be like a broken piece of the abutment inside the implant. And so they weren't sure what was going on, referred him over to me. And so I told him, I was like, hey, I'm going to open things up, and then I'm going to have to assess what the situation is with the broken piece. Hopefully I can just like pop it out. So, super nice guy. He was like, yeah, do what you need to do. Go in, I do a little tissue punch, get right in, get the tissue out of the way. And my assistant was holding the surgical section, and the broken piece just like suctioned up. And the guy looked at me and he was like, and I was like, oh, I got it. And it was like literally the whole thing took like 10 minutes.
He hit the first 30-minute milestone. Done.
I literally told him, I was like, because he was getting the implant crown with me anyways. I was like, I'm not charging you for this. Like, I felt so good. And I was like, no, we got it. But those stories for me are so few and far between. So when it happens, I'm like, yeah.
Have you ever, because I've had this happen where in scenarios like that, or scenarios where I'm struggling, because sometimes it is really hard to see inside, especially if there's some blood matriculating in, where I've been chasing like cold welded abutments pieces that are like the hexing of the abutments that break off inside the implants. And I will sit there and wonder if it's still there. And I'm wondering, I'm like, it's got to be, I think it's gone. I'll take a PA and I'm like, you're not sure. And I'm like, check the trap. I think it got sucked up or something during the time. So it can happen. And I feel like you really got to track. Like, I'm glad you guys caught it, because otherwise you might have went in and been like, where, like, what, is it still in there? Do I need to drill more?
No, totally. And like, I always remind patients, I'm like, when I'm looking, it's all the same color. It's not like this is one color and this is another color. Like, it is all the same.
I love it when you're right. I love it when they color code it so you can kind of tell the difference between the two. Another trick I've used, especially for those like broken abutments, is I've used endo ice. Inside, I'll put endo ice on the tip of a cotton pellet and press it into the implant. And sometimes that cold contracts the metal and separates something that might feel cold welded. I know cold welded isn't like, it's like press fit tight. And that'll loosen it up, and I'll inject mineral oil and then do it again. I will repeat the process. And sometimes that's been enough to get off a stuck abutment. And so that's just one little trick that I've picked up that has helped. And a part of this, I'll tell you, part of this is that we send out our pearls to these doctors, and hopefully these pearls help them get to that next level of surviving these kind of cases. But endo ice has bailed me out of a lot of kind of stuck abutments.
I feel like my favorite part about what we do as like lecturing and talking about these things is I was really grateful that when I brought to the idea to some of our KOL partners about like starting to lecture on implant complications, they were like so excited, and they were, we created this whole lecture on it. And what's been so cool for me is every single time I go give a lecture on this topic, at the end of it, all of the doctors there were like talking about the random things that have worked for us. And like the random, like I remember one time, I think I was in NorCal and I was lecturing on this, and the doc was like, yeah, some part of the abutment was stuck. And I just took a healing abutment and I put it in, and then I took it out and the broken piece came with it. And it's like, it's just like those like random pearls where it's like, that's so smart. And then when you're in it and you're sweating and your blood pressure is really high, you remember that and you're like, okay, well.
No, it's awesome. We're rounding our 30 minutes. So we're gonna wrap up our discussion on dealing with these like essentially internal prosthetic complications. And we're going to come back and hit up some more implant complications from a different angle with you. Okay. We're going to have lots of episodes with Varisha, guys. So she'll be back for many more. Guys, thank you for getting unfiltered. And thank you, Varisha, for coming in here and talking to us today. remember no one's getting paid for this. Neither one of us are getting paid for this. Remember to like, follow, comment, and share with your friends, because we do this for the passion and love of dentistry. Thank you.